So next is Hilar cholangiocarcinoma or perihilar cholangiocarcinoma or Klatskin tumors. 75-year-old woman with an intractable itch for several months now complains of jaundice for a few days. She is otherwise well. How would you approach this patient? So this is a woman with painless jaundice. In the background of intractable itch suggests obstructive jaundice. The most likely differentials would be tumor at the head of the pancreas, a tumor at ampullary or periampullary region, or extrahepatic cholangiocarcinoma that are obstructing the biliary system. A simple ultrasound scan will tell us the level of obstruction, and depending on that, we will need to decide whether we should do a CT, head of pancreas, if it's a distal CBD, or if it's proximal CBD, then we might need to do MRCP. The ultrasound, and this will also tell us whether this obstruction is intrahepatic or extrahepatic or both. If it's extrahepatic and intrahepatic, it means the obstruction is the CBD. If obstruction is at the hilum, then it's something in the proximal CBD. So the ultrasound showed only intrahepatic biliary dilatation, and MRCP was then performed. The MRCP reconstructed view is as shown next. What are the considerations on this image that will help you determine the management plan? 1, 2, 3, 4. This reconstructed image of biliary tree shows markedly dilated intrahepatic ducts with a cutoff at the hilum. The right and the left hepatic ductal system also appear isolated from each other, suggesting a high level of involvement of the Klatskin tumor. It will be important to look after 15 minutes delayed views of the MRI to best define the hilar tumor size, its extent, its to see whether right and left ducts are involved or both are blocked, and to see whether it's involving the portal vein or involving the hepatic arteries, and the sizes of the both lobes of the liver. If surgery is possible, what would the planned operation be and the extent? The surgical resection of extrahepatic biliary will go down distal extent down to the suprapancreatic border, proximal to as high as possible for a negative margin, keeping in mind the need for high hepatocholangiocarcinoma and the tissues hereof. Liver resection with either right or the left hemihepatectomy, depending on the vascular involvement and size of the remnant liver, and caudate lobe liver resection with the as a Klatskin tumor, caudate lobe resection en bloc with the main specimen as Klatskin tumor, as well as are well known to have involvement of caudate lobe biliary branches, lymphadenectomy, and then hepatocholangiocarcinoma reconstruction. Thank you.